Well, good afternoon, everybody. Thank you for joining us for this TPOPP training. This is the first time we've done this on the road, and we have our faculty this afternoon. I'm going to allow them to introduce themselves, and then we're going to take a few minutes and go around the room and have you introduce yourself to us, at least initially. We probably won't go back if we have others join us. But anyway, this group is representative of the leadership team, 3 of the 9 or so of us that serve as the leadership team for the initiative, the TPOPP initiative in the state of Kansas and Missouri. I'm John Carney. I work at the Center for Practical Bioethics and have been there since 2004. My professional history is really in hospice and palliative care, dating back to the mid-1980s in Kansas. So I've been around a long, long time in this field, and have spent the last dozen or so years in Kansas City at the Center for Practical Bioethics, and my work has been primarily in community work around issues of aging and end of life. And I currently serve as the CEO and have been in that position for the last almost 5 years now. And then the other 2 team members here are going to be introducing themselves, one from Wichita and another one from Kansas City. So go ahead.
I'm Susan Fry, and I'm a registered nurse. I'm currently a volunteer with the Bioethics Center, and I have had my professional career both in acute care and in long-term care. So I kind of represent the long-term care side of things. I most recently was with Presbyterian Manors of Mid-America, which have 18 communities in Kansas and Missouri, so I sort of know both sides of the states, both states in this process. So.
And I'm Karen Porter Williamson. I'm a palliative care physician at the University of Kansas in Kansas City. And so help run an inpatient palliative care consultation service there, also do palliative care clinic, run a palliative care fellowship, educate medical students, residents, fellows, all along those lines. And have been working with the Center for Practical Bioethics as the medical director for TPOPP in Kansas and Missouri since about 2008. So we've been working at the bi-state level, and then my job at KU has been to be the institutional champion at the hospital for how do we implement TPOPP, how do we do a better job of having serious illness conversations, but then building the appropriate documentation tools in our electronic medical record, really overhauling all of these things to do a better job for patients and families. So in 2008, I started to realize that we could do a really great job of goals of care conversations in the hospital, and that's all fine and good, but when the patient leaves and goes home or goes back to Manhattan, or, if they don't have the right tools for that information to move with them, then all of our great goals of care conversations are lost. And then they get sick again, and we're back where we started. And so when I realized that deficiency in our system, I said, well, we have to fix this. Little did I know, I'm a Pollyanna, little did I know what I was getting myself into, but I'm really happy and proud of the work that we're doing to try to improve this aspect of medical care, and we're really happy and thankful that you guys are here today and interested in what we're doing.
And I understand from Blaine Miller that this is part of the process that you're using to kind of assess the community needs in this area and really begin to respond to those community needs. So we understand that this is an initial step that you're taking in the process of trying to figure out how it is that you would be able to take on this initiative and make it meaningful for not only the healthcare providers in the community, but also for the residents who live and stay here and would just as soon spend their final days in their own communities rather than being shipped off to foreign lands and other tertiary environments where maybe they don't get to see their family and friends as closely as they can. All right, we do want to make sure that we declare our conflicts of interest. I have no particular conflicts to report, and I'll let the other 2 speak for themselves, but just to let you know that the Center for Practical Bioethics is a nonprofit organization that offers membership services and products on advanced care planning services to individuals and organizations on a complementary and fee-based services. So we do benefit from the payment by providers who choose to use our resources in their communities, whether that be for advanced care planning. There are some also minimal charges that we assess for the development of the documents that we use in implementing the TPOPP in the communities, but those are pretty minimal in terms of cost, basically, that we incur as a result of that. So we really don't benefit any other way. And the project is really financed through what little grants we can get from sources around the state. This particular visit was funded by a grant that we've received from the Kansas Health Foundation for this year to help promote education among the rural communities in Kansas, and in partnership with KU Med. Your conflict of interest.
Oh, I have no conflict of interest.
And Karen.
I have no conflicts of interest. I wish I did. But I'm kidding.
All right, so this afternoon we're going to explore the role of the TPOPP in establishing the goals of care for patients with serious illness. And so we'll talk a little bit about that. But most of the clinical presentations will be conducted by Susan Fry and Dr. Karen Porter-Williamson. My background is primarily in administration and working in the community setting, so I'll be hopefully talking a little bit about that with different providers in the community and coordinating that work. We'll also do a TPOPP overview and talk about the program elements, how to actually implement these within your own facilities, and the readiness that you have in terms of the work that you're doing collectively as a community in deciding whether you're ready to launch, go live, and be able to start implementing the program in your region. And then also we'll be talking about functional trajectories of illness and the patients with serious illness and how they might, in their weeks and months, display certain characteristics that would be appropriate for them to be enrolled in the program or involved in serious discussions with their clinicians around goals of care. All right, for the objectives, we're going to be discussing the effectiveness of the POLST paradigm initiatives and how they relate to TPOPP. The POLST paradigms are physician's order for life-sustaining treatment. It's been around about 25 years. This is actually, the TPOPP is actually one of the initiatives that's been adopted throughout the United States. Most of them have similar acronyms that identify them, and we'll be talking a little bit about that later. We'll also be describing, as I mentioned, the functional trajectories of patients with serious illness and that they display prior to death, and how to really kind of recognize through the clinical process whether or not a patient is appropriate for a goals of care discussion. And then incorporating TPOPP into the serious illness conversations within the practice setting, and then making sure that those orders that are written, those goals of care that are discussed, are then shared across the different settings where the patient is residing. And then finally, we'll update you on the progress that we're making on the Kansas-Missouri TPOPP initiative throughout the bi-state region.
All right, so we'll start with a story that probably most everyone in the room will be able to relate to. I'm going to tell you the story of Roy. Roy is a 71-year-old gentleman who has severe COPD and mild dementia. He's been in the hospital with pneumonia, and now he's back in the skilled nursing facility trying to recuperate. He ran into some difficulty, though, with increased shortness of breath and hypoxia, mental status changes. EMS gets called when he wasn't responding, and found that his O2 sats are down in the 70s. He'd had some recent conversations with the staff at the facility saying, you know what, I don't want to be kept alive on machines. If it's my time to go, I'm at peace, I'm ready to go. Of course, EMS, I don't know where those conversations are documented, how that information is shared across the providers, but when EMS gets called, it's not there, in a form that's usable to them to impact their plan of care for treatment. And so they do the right things that they do. They take him into the hospital. He's unresponsive. He ends up getting intubated, and he has respiratory failure from his COPD. So now the family, his daughter gets called and she's able to come into the bedside. She comes in, and then over the next few days, Roy becomes more responsive, but he's not getting back to where, he was even before. He's agitated and restless, and his daughter's pretty distressed that his wishes weren't followed. Has anybody been there? Have you all been at this bedside? Yeah. We've all been at this bedside. So they make a decision around goals of care and come to the conclusion he'd rather be on comfort measures, so gets off of the life support machine, is now on a comfort-directed approach. So they make plans and get him back to the skilled nursing facility. He's on comfort measures, and a few days later, he ends up passing away. You know, this is a really hallmark story where somebody is in a place where they're dealing with a serious illness and they know how they feel about it. And they may have told their medical providers how they feel about it. They may have told their family and not their medical providers, or they may have talked about it and even written it down and had an advance directive that says how they feel. But when the rubber hits the road, the documentation, the people, the whoever is not all in the right place at the right time at the moment the patient gets sicker, and the information's lost. And then the automation of our system, you know, kind of takes over. And people end up having things happen to them that they wouldn't wish to have happened to them, because we have not systematized and put into the workflow, making sure we know what that person's wishes and preferences are, and making sure that that documentation is visible across the continuum of care for all of the medical providers. So it's like there's this missing piece. And when we think about TPOPP, the reason that this becomes so important is that it's about building the infrastructure to fill the missing link, so that as medical systems, we're able to do a better job, you know, of understanding how people feel about things, and then having those wishes in a form that can be reviewed and respected by the different types of medical providers that a person runs across as they go across the continuum of care. So we know with all of that advanced directives really aren't enough. You know, they have a wonderful purpose, but they're not enough when we come to this moment of wondering and trying to make sure that we're honoring somebody's wishes. So, you know, when we look at the downfalls of advanced directives, they may have been written a long time ago, so they can fall out of context with the patient's present condition. They may be in a bank box somewhere, you know. I have my father's advanced directive. It's in a pile. I think I know the pile, right? And I know what it says. I remember what it says, but if I needed to present that document, I'd have to go home and rifle through it. This is videoed. He's probably going to be like, what? You're supposed to have that thing on you at all times. So anyway, that's really the purpose here, is to start to say, how do we take this beyond advanced directives when somebody's in a place where they want orders moving with them, and they're prepared, and they're like, what do I want the medical system to do if the bottom drops out tomorrow and I'm at home or I'm at the nursing facility? So TPOPP is a program that's really designed to improve the quality of care that we're providing, how we talk as providers, how we talk with patients and families about what's important to them, and then also how we translate that into the infrastructure that's necessary in the hospital, in the nursing home, in the home for hospice providers, patients at home, and for EMS. Our EMS leader, Angela Farrell, she says, you know, the motto of EMS is you call, we haul. But they've got to know, you know, they've got to be included so that we're all tied together as a community of providers taking care of that patient.
And I want to comment here, just to be real clear, and we're going to state this over and over. TPOPP is not intended to be in place of advanced directives. Advanced directives are things any of us, and hopefully all of us, have for some future event. But the TPOPP is at that serious time of illness when you really wouldn't expect this person to probably live with it, to be alive within the next year. So it's for end of life, serious illness discussions for that illness at that point in time, what their wishes are. So, so TPOPP is actually designed, and the form is designed to be a physician's order. And it is to be discussed with the patient and their family, and signed by the patient and or their family, and by the physician, so that it becomes the physician order. Oh, I see. Okay.
Are we not on
We
the
have the
same
whole
page?
slide. They don't have the whole slide.
Okay.
Sorry about that.
So it becomes the physician's order. Then the question for the community, how does that physician order transport between the various entities? And that's really the work that has to happen at the local level. It's based, again, on conversations among the healthcare professionals, the patient, their agent. What do they want to have happen to them for this course of illness at this point in time? And then the form travels with the patient across care settings to ensure that their wishes are honored throughout the whole healthcare system.
Carl, you want to add anything on that?
So what it is transparent. It should be used by, it should be well understood by everyone involved. The patient, their family, the care providers. The patient or the surrogate signs the statement, and then it reflects their current treatment preferences, and it's translated into actionable physician orders. We're going to talk a lot about this the rest of the afternoon, how we make that happen.
Just to go back, one point I want to make about the signing of the document, the TPOPP order, is normally a physician order doesn't require a patient signature on it. I mean, a physician writes an order and it goes into the chart or whatever, and people fill it out. You know, the other professionals complete the document, the pharmacist fills the order. But a physician order for patient preferences that we're talking about in TPOPP, we have put into place a requirement that there be either the patient, him or herself, signing the form saying, yes, this is what it is, what I want, and the doctors talk to me about it, and I'm agreeing with the physician, or I've instructed the physician to do this. Or a representative of the patient signs saying, this is actually in concordance with what we believe, or we're concurring. That signature can be by someone who isn't necessarily a legal authority if the agent if the patient hasn't actually appointed an agent and can no longer appoint an agent, all right? So you can have somebody sign the form who is a patient representative, but the form isn't valid unless it has either a patient or a patient representative signature along with the doctor. Okay, those are both of those signatures are going to be required on this form. That's not true on a directive, obviously. A directive, a patient signs, it's either witnessed or notarized, and the doctor doesn't sign it. So this is another differentiation that Susan was talking about, the difference between a directive and a physician order. A physician order is written by a doc, and in this case, concurred with by either the patient or the family.
Another point to make on this is not a form to be handed out and the patient and or their family fill it out. This is a documentation of a discussion with the healthcare professional and the patient and their family.
Yeah. Karen's gonna talk a lot about that.
And we'll go over how to fill the form out in the last hour. TPOPP is based on the belief that individuals have the right to make their own healthcare decisions. And here is an example of, or a schematic, if you would, of the difference between advanced directives and the TPOPP form itself. So for all of the advanced directives are healthcare proxies, they're for all adults. All of us should have an advanced directive. It's telling our care providers, in the future, this is what I want to have. If this happens, this is what I want. So it's completed for the future, not right now, immediately, my illness, I rethought this and maybe I have a few things to add to it, if you would. It's in effect when decision-making capacity is lost, contains no medical orders, and there's a lot of confusion I've found in my practice in both Kansas and Missouri. I've had people come in, or nurses tell me, well, they have an advanced directive. Well, the advanced directive is not the physician order. The physician needs to write an order based on what the advanced directive says. So that's the distinct difference between the TPOPP, which is an order, and the advanced directive, which is, this is what I want to tell my healthcare providers to order for me, if you will. And the advanced directive, just as Karen says, may not be available in all settings. You know, how many of you, yeah, you admit somebody and they said, well, the spouse says, oh yeah, their advanced directives at home. Me, I'm one of those. My advanced directive is at home in my desk drawer. TPOPP then is the progressive chronic illness that's there. You wouldn't expect them to live.
You wouldn't be surprised if they were to die.
They wouldn't be surprised if they die within the year.
Yeah.
Yeah.
An important distinction. So it wouldn't surprise you if that person were to die in the next year. Does not necessarily mean they have a prognosis of 12 months or less, right? But it would not surprise you if that person were to die. And a little important to say, it's different than being surprised they'd be alive in a year.
Yeah.
Right?
Yeah.
So it wouldn't surprise you if they were to die in a year. That helps define a broad population of people where it's important to be thinking about these types of things. You know, like if it wouldn't surprise me as their doctor if they were to die in the next year, I should ask myself as the doctor, have I communicated that to them? Do they understand why it wouldn't surprise me? You know, what are the elements of their medical condition that cause me to worry? Have I explained what's going on? If I'm seeing a pattern of illness that we'll talk about, you know, how well am I doing and how well does my patient and their family understand where they're at?
This isn't particularly a welcome conversation, and it's often not initiated by physicians. So part of the benefit of embracing this in a community perspective is to encourage these kinds of conversations to happen before the crisis occurs. So it's not necessarily an emergent discussion. It's taking place over the course of time as a patient's chronic disease progresses or multiple chronic diseases progress, and the patient has episodes that place the patient in more vulnerable positions than they were in the past. So we're going to talk a little bit about that later on in the afternoon too. But basically what this is to facilitate is to help get these conversations started in a meaningful way so that the conversations can be initiated by the family and the conversations can be initiated by the doc, depending on where the patient is in the course of care. So it really is a facilitating mechanism. And it's not all about the form. It kind of boils down to the form later on, obviously, when you need it. But it's the real benefit here is that there's a dialogue going on between the care provider and the patient and the family, and in many cases, the agent that needs to be involved in that conversation so you have a better understanding of what can benefit this patient, what does the patient want, and what ought we to be doing as care providers in the community, making sure that the good outcomes that we're expecting can happen. Is there a question?
Well, and you probably maybe jumping ahead, but when you mentioned you know, traveling or whatnot, are they recognized state to state then?
Okay, the question is from one of the participants is asking about the transportability and recognition across state lines of the forms as they exist. So Karen, you've had this experience. Go ahead.
So I think that the most important thing about these is that when a form moves anywhere, the national paradigm forms are built in such a way they're standard. You would completely recognize a West Virginia form, an Oregon form, they all look the same. As a standard also, whenever a form comes to you from wherever, regardless of if it's a TPOPP form, an Oregon form, a New York form, what needs to happen is it needs to be reviewed by the providers who see it. You know, discussed whenever possible with the patient and their surrogate. Sometimes that review is not possible at all. There's no surrogate and the patient's incapacitated at that moment. But so the concepts of how we behave with the forms are the same every time. Reviewed and then considered in the care planning that's being built at that moment. I'll tell you, a West Virginia form showed up to Stormont Vale, I think, in Topeka, Kansas, and they immediately recognized that it was a POLST TPOPP type document. You know, on the form, there's the physician's signature and the physician's phone number, and so there was easy and direct communication between the provider in Topeka, Kansas, and the provider in West Virginia. And, you know, that we really like to see that happening. So in terms of legal reciprocity, I think we, whether or not that's built into legislation, may happen some places, may not. What we stick with always is the standard of care, always. And so a document shows up that outlines orders related to that patient's preferences with regard to life-sustaining intervention. The standard of care is you better review it, and you have evidence of that patient's wishes. They need to be honored. So regardless of what state it comes from.
Good question.
Great question.
Good question.
So
Now,
we totally stole Susan's thunder. We're going to shut up and let her continue.
no. In terms of the last point on here, accompanies the patient across settings. That's really the work of the local community that is ahead, is how does that form then translate for EMS? How does it translate for nursing homes? How does it translate for the hospital? What do you do with it when you receive someone with a TPOPP form?
And the obligation of the Community Coalition is to provide some assurance to both the provider community and to the residents in that region that we're going to honor this in every setting that you find yourself in. So the work that you have is making sure not so much that, you know, people are signing this in blood from your perspective, but that everybody's willing to cooperate and work together to say, yes, we get it, we understand it. If it comes from KU and Carnes sent it home with a patient from here out of Kansas City, then you guys are going to do your best to make sure that when it gets here, it's recognized and implemented, and then if the patient ends back up at Republic County Hospital, they know what to do with it when it shows up there, and the signature on the form is recognized in such a way that they know how to translate that order into another order here, so that we're not disrupting the kind of care that this patient wants along the way. Does that make sense? Yeah. Okay. All right. So the physician order for life-sustaining treatment began, as Karen, I think, mentioned, about 25 years ago in the state of Oregon. And they adopted the same thing that Kansas and Missouri are adopting, which is a standard of care approach. They did not seek legislation. Many, many states across the nation have implemented laws to implement POLST initiatives, the physician order for life-sustaining treatment. We have not. Part of that reason is that this began in the Kansas City region, and Carnes on one side of the line, the center sits on another side of the line, and we just realized that there was no way we were ever going to get an identical law passed in the legislature in Topeka that mirrored the one that was going to be in the assembly in Missouri. So we decided at that point we were going to do a community approach and say we're going to do this through a standard of care and recognize the scope of practice across the lines. That then kind of got reinforced over and over again and really became, I think, the best way we considered, even though in many places out here you may not see one from Nebraska or anywhere else, it may not be an issue for you. But at the same time, we felt like this was the best way for us to really engage the community in a meaningful effort to make sure that we were actually doing a good job of transferring the information across providers as the patient moved from one location to another. As we've already mentioned, it was an approach to ensure that the care received agrees with the patient wishes. So we're honoring patient preferences from the moment this document is signed across all settings, and that it is actually a set of medical orders. So again, the differentiation between advanced directives and medical orders, and that there was this commitment that they were making 25 years ago that we were going to monitor the success of this, evaluate the success, and conduct research to find out if it works. So we kind of validate it and figure out whether it works. And there's a whole body of evidence now that shows that these types of documents really do make a difference for patients in the final stages of their illness. The term POLST paradigm is used because it stands for the Physician's Order for Life-Sustaining Treatment. But as Karen mentioned, there are like 9 different elements that every single state has to use in order for them to be considered to be in concert with the National POLST Paradigm Task Force. So we all agree across the 44 states that now have it in place that we will follow certain sets. So it has to be a distinctive color. You guys don't have the opportunity to change it. The state of Kansas decides together collectively what we're going to do, along with the state of Missouri, and then we move forward.
And we can't change that form without going to the National POLST Paradigm Task Force.
Now, we can make suggestions, and we have, and Karen will talk about those, some changes that we've made to the form, and now are actually being adopted by other states that we've made, that we suggested that they do. But at the same time, it's this kind of uniformity of the look allows us for that reciprocity to take place to make sure that people across state lines really understand what it is. Anyway, these are just some of the other states it's called medical orders for life-sustaining treatment. It's called provider orders for scope of treatment in West Virginia. In TPOPP, we have the nicest term. It just sounds better than.
We did that. We did that because we wanted it to be really blatant that the words patient preferences are in the title. This is about transportable physician's orders that represent patient preferences. This is not doctors sitting in their offices trying to decide who gets what and who doesn't. Absolutely not. Transportable physician's orders for patient preferences. And so it sounds kind of silly, but I actually love it. And I just hope everybody else changes it. They won't.
All right, this is a snapshot of the POLST Paradigm Task Force website. And if you want to go there, it's polst.org. You can click on any state, and what will pop up to the right is the office within that state and the representatives and how to get in touch with your leadership. So for us, it's, I think Matthew's name's on there. And we are currently in the process. You'll notice there's different shades of the different states. There's only 3 that are still white. Those are the only 3 states that do not have anything really going on right now in the POLST paradigm. You'll notice some of them are really, really dark. Those are the states that are more mature, that have advanced in the work that they're doing. They've obviously begun their work in documentation and research areas. So those are why West Virginia and Oregon, California, and some of those states are. Those of us that are in lighter pink, there's a lighter shade, are what they call endorsed. You'll notice Kansas and Missouri are still even a lighter shade than that. That's because we're in development stage. We submitted our endorsed status application a couple weeks ago, and we'll hope to hear within a couple weeks. So we will be turning to the same shade as Colorado, hopefully within the next couple of weeks.
Hopefully. Cross your fingers. So talk a little bit about data behind POLST and effectiveness of these paradigms. So a study that looking at 90 urban and rural nursing homes in multi-state studies. So this was in Oregon and West Virginia. The darkest pink states, you know, is where most of the data, and an area in Wisconsin, La Crosse, Wisconsin, where there's a lot of POLST forms and good structure around the research. So they were comparing POLST with traditional advanced care planning type documents, looking on the effect of the presence of medical orders and effect on symptom management, effect on use of life-sustaining treatments. So there were about 817 residents who had POLST there, and about 1,711 in the study totally. So the residents with the next slide. The residents who had POLST forms were more likely to have orders about life-sustaining preferences or not, whether or not they wanted CPR. There were no differences between the residents with and without POLST on their symptom assessment or other management measures. Other results. POLST was more effective than traditional methods for limiting unwanted life-sustaining treatment. So POLST users who had comfort measures on their form, and you can kind of look if you have that. So documents that said DNR with comfort measures, those guys were significantly less likely to be hospitalized at the end of life, also significantly less likely to receive interventions, intensive interventions that they had indicated they did not want. This is also good to know. The POLST users who indicated they wanted full treatment. So it's not just a DNR. You can put on there you want full code, full treatment. If you're a person who says, come hell or high water, that's the only way I'm leaving the face of the earth, you can have the form documented. And it turns out in this study, the folks who said that were even more likely to receive intensive services than people who had no form at all. So when we look at that, it's important to note the form is not biased towards saying only don't have it. If somebody wants to have it, they can use the form to indicate that. Now most people, and in my own practice at KU, I'm finding most people, they really want those things in place if they don't want something to happen, you know, or if they want to not get coded, but they do want other interventions, you know, beyond a comfort measures approach. So
I think it's really important to hear that second point that she made, that a lot of people are critical of POLST and the TPOPP initiative without the knowledge, the fact that if people want something, they're more likely to get treatment if they choose full treatment than if they didn't have one at all, especially for frail elderly. So for those people who want it, it really is a good protection measure for them to have it, to be able to check that box. So there is benefit for that, especially for those that are in advanced age or an advanced illness otherwise, if they're saying, I want to have full code.
I had an interesting patient. This was probably 4 months ago, and the patient herself was incapacitated. Her daughters, and the patient living in a nursing home type setting, and the daughters were her surrogate decision makers. And we were just going live with TPOPP at KU at that point. And so, and they knew, they did not want her to get coded if she actually coded, but they did want her to have everything up to the point of getting coded. They just didn't want her to get coded if that actually came to pass. And so they would never sign an out-of-hospital DNR form because they were very afraid, you know, of the out-of-hospital DNR being over-interpreted. They would only complete the TPOPP form because it allowed them to say, don't code if in actual cardiopulmonary arrest, but if significant change in her condition and she's not coding yet, then full treatment. So really important to note that it takes this conversation another step further around what are someone's goals of care, what would they and would they not want to see happen in the midst of a major change in health condition short of full-blown cardiopulmonary arrest. We also know that there's good data around the concept of over-interpreting a DNR. You know, somebody has a DNR order in place and all of a sudden they're not getting IV antibiotics or a transfusion. Well, we need to stop doing that, right? The code status order is about their code status. The rest of the treatment plan needs to be developed based on the medical information, the goals and preferences, and what are the medical interventions that may or may not help that person, and working with their medical providers to come to that conclusion. So where I really come to love the TPOPP form is that it empowers the patient to state more specifically how they would want their medical care approached and what their goals are, you know, at that time.
It's not unusual to hear families concerned if they agree to a DNR that the patient or resident won't get any comfort measures. So this is a way to get that all sorted out about what will happen clearly for the family, the patient, from the physician's point of view. So
yeah. Okay, why don't we move forward? The National Quality Forum, you know, this is the clearinghouse of what ought we be doing in quality, providing quality care. And so the National Quality Forum back in 2006 brought this on, you know, as we need to be thinking about this as patients are dealing with serious illness. They need to have preferences documented, surrogates documented, and then systems need to come into place. And so they looked at the POLST paradigm as a marker of high quality.
So a brief history then, Karin mentioned in 2008 we began the process in Kansas City of getting this thing kicked off the ground, and worked with a variety of different providers in the Kansas City regional area. We had EMS, we had long-term care, we had health lawyers, we had hospital systems, all represented, and really began the process of trying to figure out whether we wanted to go through a law or whether we wanted to use standard of care, which we quickly settled on in terms of what we wanted to do. So anyway, we got the National POLST Paradigm Office on the phone with us and started working through it, developed our guidebook, which we have for clinicians and also for families. I think you have a family one with you, and we do have clinical guidebooks that we can show you. It looks like this right here. It actually takes the physician or the clinician through the process of actually doing it, and began our education and training. We then got some advice from the National POLST Paradigm Office that we needed to pilot it. They did not suggest that we do it in the Kansas City area. You said you have too many providers, and you're never going to be able to really gauge your success, you need to start in a community that has fewer number of hospitals, fewer number of EMSs, and fewer number of nursing homes. So we went to Topeka, and they were more than welcome to have us. So we started there and began implementing. We did about a year and a half, almost a little more than a year of training over there, and began the process of implementing in 2010. We learned a lot in that process. We learned really how important a community coalition is, how much investment there needs to be made in terms of each individual institution making a commitment to integrate this into their practice and their workflow, which was very, very important. We now have thousands of them that have been written and in place in Topeka, and they're moving forward, and we've had good success there and have replicated that in other communities. The goals of the TPOPP program are obviously then to document treatment preferences, translate those treatment preferences into physician orders, and communicating them across the healthcare setting. And improving EMS's ability to treat according to the individual wishes of the patients. This was a big deal, especially in in areas where there are multiple EMS providers. And also in some cases where we have different jurisdictions where the EMS provider may not be associated directly with the healthcare community and maybe more of a standalone agency. It was very important to bring them in and to involve them in the process and the discussion, and this has worked well. And they really do want to know what the patient preferences are when they're transporting a patient, and should they start this or start that, depending on what they do and if the patient codes or has other complications during the course of the transport. And then finally, consolidating the documentation while complying with other state laws related to advanced care documents and those kind of things, as well as the Federal Patient Self-Determination Act, and then recognizing HIPAA in terms of the limitations and the actual mandates from HIPAA in terms of being able to share with people information that needs to be shared in order for them to have the information they need to care for the patient right. So what you want to do is make sure that we're not just limiting how that information is shared, but we're sharing it with the people in a way that makes sense to them. So the elements of the provider implementation include an agreement on the importance. And Karin, this is really outcomes, so I'll let you kind of talk about the elements of the provider implementation. The agreement on the importance and getting the executive leadership from your institutions that are involved. So those of you in Concordia, making sure that the executive leadership there is on board, that Blaine is on board here, that your EMS people are involved, and that everybody's in agreement, your medical staff and everybody else in terms of that, and then selecting your champions and getting them to come forward. But it's very important that they do this on the individual sites, and that the policies and procedures and protocols are in place. And Karin, that's been, I know, a big part of your work that you've done at KU in terms of the importance of making it work.
Yeah, so when it comes down to the rubber hitting the road, there has to be for the community, really a commitment on the part of all the core groups of providers and facilities to say, yeah, we want to do this. You know, that's really step one in order for it to work as efficiently and as well as it can. So it's great to see folks from across the continuum, and I didn't hear about anyone from EMS. That was the only group.
He hurt his back, and he called this morning, and
that's too bad. Yeah, well, so there's a lot of good resources, you know, and our EMS leadership in Kansas City, she's on the national EMS task force, and it's kind of helps at that level too. So a lot of resources for EMS, but really the starting point is everybody saying, okay, we want to commit to doing this, and then identifying the lead folks at each place, you know, to start putting heads together and say, okay, what does this mean for us here in our community, you know? And that usually means asking the bosses what they think and making sure that all the levels at each institution is signed off, you know. So the first things at each place are talking about, okay, why is this important for us here, and engaging that leadership, you know. The next step after that is to say, well, okay, now we've all agreed that it's a good idea to do. We've got the approval from the heads of our various workplaces. Now we need to figure out, how do you make the rubber hit the road? And so you got to write policy and procedure around it. for hospitals at KU, you know, this started with us writing the policies and then looking at what we had in place already. We already had policies in place for resuscitation status orders and how we handle other out-of-hospital orders. What do the medical staff bylaws say? So my first job at KU is to really crosswalk all of the things that were currently in place, you know, and then make sure that they were updated to include, and how do we include TPOPP into that. And that process, I'll tell, well, KU is a great big place, but I think that there's infrastructure at a lot of places where you've got to check, you know, check the boxes. And it took us, I mean, gosh, 3 years? 3 years to, and
It doesn't have to take you 3 years.
well, now we have, now there's tools for not reinventing the wheel,
Yeah.
you know, and smaller systems I think are probably going to be more simple in terms of you have to get fewer people to agree, you know, in a smaller environment. So, and we actually took a step back, and we'll spend time on this later. We took a step back and said, well, how we do resuscitation status in our environment isn't good, so why don't we overhaul that whole thing at the same time? And so we actually overhauled how we do inpatient code status orders at KU to mirror TPOPP. So now our whole inpatient system flows inpatient to outpatient. So we took a step back and said, what all here do we have to fix in order to do this right? And it turns out we didn't just have to implement TPOPP, we needed to fix 5 other things, you know, but now hopefully, and it took longer, you know, but working all the way through that process, I think we're now ended up with a product that's actually really meaningful, and that creates sustainable change. And now how we document goals of care conversations is completely different. I have doctors calling me, I never imagined this would happen. I have doctors calling me saying, well, now I have all these tools in place, but I need you to teach me how to do better conversations with people when they're seriously ill. Okay, so now I know that's a good problem. So you build it, they will come. So I'm probably getting off track with the slides, but you know, there's a process that we go through, and it's a process of learning. You know, at KU, we are constantly figuring out, oh, I thought that was the right way to do that, but it's not the right way to do that. Now I'm going to take a step back and, you know, reinvestigate, reinitiate, and build it right. So we have a real vested interest in you guys, if you're interested in doing this, not reinventing the wheel. Like if we've already figured out how to go down a road the wrong way, be like, don't worry about that one, go this way instead. You'll get where you want to be faster.
So some of the resources that we've handed out today are actual tools that are in the toolkit, but there are more tools than that. We actually have sample policies and things like that that you can actually download, look at, figure out what you need to do in order for you to implement them at your own location.
So we've kind of talked about all of these things already. It's important to know that TPOPP is not for everybody. You know, if that person is a person where it wouldn't surprise us if they were to die in the next year, then consideration of a good goals of care conversation, a serious illness care conversation between that patient's provider, the patient, the family. And when you have that conversation, there'll be some outcomes. It may just be a conversation that gets documented in the chart. It needs to be documented in a way that all the providers can easily see it. Now, that's a major trick, but it's important that those conversations are easily visible, even if an order did not result, you know? It may be the outcome of that conversation is they want to make an advance directive or a power of attorney, and that's it. And that's another good possible outcome of one of these conversations. For some people, they'll say, now I get it. Now I want you to know what my wishes are about these things, and I feel so strongly about this, I want a set of orders that moves with me because I want EMS to know. And if I'm coding in my living room, I don't want them coding me, or I do want them coding me. So TPOPP's not mandatory ever, always a voluntary thing for the patients who want it when after they've had a serious illness conversation with their provider. So, so we've talked about this about a little bit. What is a serious illness conversation? I actually got to have lunch with the doctors And we went all through what's a serious illness conversation. You got some folks who were there, members of Aledade, which is an ACO. I don't know, anybody here with Aledade? All right, well, that's okay. That's okay. So there's two sides to this coin. There's one is how do we do more, better, earlier conversations about goals of care with our seriously ill patients. And there's actually a structure around that. That's one side of the coin. When we do a good job of that communication, the other side of that coin is TPOPP, which is the infrastructure in the community to make sure that those good conversations outcomes get translated and move with the patient the way they need to. And you can't have one without the other. So that means that anybody wanting to go down this road has to invest in the concept of a culture change, which is huge. And it's years long, years long. I mean, if we actually achieve the goal of TPOPP in my own institution and I decide, and across Kansas, for me, that's when I get to retire.
So make it a long
I'm
process.
40, I'm 45, I have 20 more years to get it done. But thinking about that, when we really think about changing the face of providing good communication and better health care for patients dealing with serious illness across the board, we have to be prepared that that's a long haul. But that's the right thing to do, and so we should be doing that.